I think the most important aspect is to work with people in that area. Sometimes I do feel people in the academic, they work on research only, but the application of the research is somehow disconnected to real life. It's important to work with people in the policy and people working frontline in the NHS. We might show something like it works on paper, but people in frontline, they may tell you this doesn't work.
Talk me through what this study is about.
This is a study about second primary cancer instance because it's becoming a concern for many women living with breast cancer. One reason behind that is overall breast cancer survival is improving substantially. So for example, in 1970s, 40% of women can survive 10 years or more. But in 2010s, we have almost 80% of women can survive 10 years or more. But also, there's an inequality in breast cancer survival. It's been long-standing reported in the UK data. So, for example, for 5-year survival rate, 90% of women from less deprived area, they will survive 5 years or more, but only 80% in people from most deprived area. So this prompts us to think about if there's also inequality in second primary cancer. So we did this study to use the data from cancer registry in England. And we link to hospital data, death registration, get the information on comorbidity, death, it's all kinds of information. And then we use the area-based deprivation measure as overexposure. So, and then we used a competing risk model because, like we said before, women from most deprived area, they die sooner and they die more and they die sooner. So you get less time window for them to be observed to get a second primary cancer diagnosis. But we use the competing risk model in the analysis to take into account that to estimate the true risk difference, like close to the reality. And what we found is, if we zoom in here, in the most deprived group compared to the least deprived group, they have about 35% higher risk of death. Not only that, they also have higher risk of a second primary cancer. So which is not only they die more, they also within the short period they surviving, they also have more second primary cancer events. And this is a relative risk. Then we also calculate the absolute risk. So around 10% at 10 years, around 10% of them will have a second primary cancer, but around 30% of them may die at 10 years. And the difference was around 1%. So difference between the most and least deprived group, around 1% for second primary cancer and then 5% for death, which means if we want to prevent 1 cases of second primary cancer, we need to tackle inequality in every 100 women. In my presentation, we also look into the cancer-specific group, and we found the large difference in the lung cancer, and it's huge, 2 times more in the most deprived group. So this prompts us to think maybe make a recommendation to modify existing cancer program in England. So in 2021, they have launched targeted lung health checks for people at high risk of lung cancer of lung health check at like supermarket, pharmacies, like local area people can easily access. So I think it's a possible way to expand this targeted lung health check to women with breast cancer as well. In this case, you don't have to like start a new strategy and a new intervention, basically.
Wow.
Yeah, so that's all.
When we talk about socioeconomic inequalities in the context of health and breast cancer, in a country like the UK that has a centralized health system, that people don't have to worry about the out-of-pocket payment, one would not expect this to be an issue since the health system is supposed to take care of it. So from the context of that, why do you think socioeconomic is still a major factor, in spite of the fact that healthcare is supposed to be free?
Yeah, so I think very often people blame individual patients. They say they are less educated, they have a worse lifestyle factors, but over research group, so inequality in cancer outcomes network group, we have done 20 years research in that area, and then we found only 1/3 of inequality are explained by individual factors. A lot of them still due to the health system factors. imagine a patient from a more deprived area. Not only if they don't understand the disease itself, they possibly have more difficulty communicating with doctors, navigating within the system, but the system hasn't done anything to accommodate their needs. And on top of that, performance of the healthcare is not universal. The system is universal, but the performance is not universal. There are better hospitals, there are better doctors, and it's not equally distributed across the country. In the area, you have more taxes and more income from the government. They also get funding, more funding source, let's say, to contribute to the healthcare infrastructure. So what we're trying to do over group is to find out what is the interplay between individual and healthcare system factor that could possibly explain the inequality, and we can implement targeted intervention in the healthcare system to minimize the inequality.
What are these top factors driving these inequalities that could be quickly addressed, and we can quickly start seeing some positive changes, if that is possible?
To be honest, I'm not sure. Like, see from two perspectives, from individual perspective, there are a lot of work ongoing to target individuals, put more, education program on the patient. For example, in the public health campaign, they might have a targeted campaign on screening for people living in certain area. And again, for lung health check example, they wanted to target in the deprived area as well. So because the high risk population are more common live in this area. So this is for targeting at the individual. I think for the health system level is more difficult. So I think we're still learning from that. For example, recently what we have done in our group is to look at the pickup of the laparoscopic surgery, which is a more advanced technique, surgical technique, compared to you have to open patients more. So what we found is it's more quickly adapted in the less deprived area. In the hospital where they have less funds, they're slowly picking up in recent years. So the gap is closing, but it takes time. I guess probably when, for example, when a new technology coming, we need to be careful in this, time lag between areas. This is one thing I can think of, but I'm sure there are others. We need to work with people in the policy and even politicians to address that.
I can see this is a collaborative study that involves the Cancer Research UK London.
Our funder, so we are funded by Cancer Research UK. So we have 5-year program, and it's been 20 years now.
Yeah. Wow. Then the Code and Inequalities in Cancer outcome.
Name, yes.
Yeah. Oh, okay. So tell me about the journey to this research. At what point did you get involved in this, and pulling this together? What were you seeking to figure out, and what impact do you think your study could potentially have?
I think this is a starting point, because second primary cancer is not I would say it's not a big issue so far for people living with cancer. Imagine a patient they will be cared more about the diagnosis and treatment they will receive. This is something they probably will think about after you have completed your treatment and so on. So I think this study is just to, at the first point, describe what's happening in the UK and to raise awareness also among researchers and patients. Look, this is possible a concern for you. Hopefully in the future we can put in more research resources to look into why this is happening, along with other problems we have observed in inequality in survival as well. Is there anything we can address inequality together, like a joint effort, in this case, to provide the best care and outcome for these patients?
Yeah, as a scientist, as a researcher, when you look at what is happening in terms of the research into new innovations, new drugs, new treatments, and you balance it with your focus on inequality, what goes on in your head when you hear the announcement of new treatments, ambitious projects, and you also have concerns with the data you are seeing that is showing widely expanding inequality? So how do you balance that?
New technology, new drug, perfect, good if it works. But I think we always need to be cautious about, like I mentioned, the example of laparoscopy in the past few years, the implementation. It might benefit some patients. Sometimes, I mean, probably always, people from deprived area, their benefit comes at the last. So when you have a new technology, for example, recently there are lots of study on AI to detect imagings in the cancer diagnosis. Well, the infrastructure is ready for that. It's usually hospitals with funding to invest in that area. So I think we need to be very careful when we talk about AI can reduce inequality. We need to put in that in mind. They might benefit all patients, but some will come later. So the implementation is the key. We need to make sure at the beginning, these new technology are available to all, not just for some patients first.
Yeah, absolutely. Putting it together, so in summary, I would say this looks quite ambitious. Do you think this is the end, or what is still going on from this point for you in this research?
So yeah, I think this is just a beginning. So this is a descriptive, and then there will be more to come to look into the mechanisms and possibly also implement intervention to see what real effect on these outcomes. So yeah, it's a long way to go.
Probably if I chip this in, there is a lot in the UK talking about making the NHS better, improving its efficiency, addressing the inequality issues. So if we want to integrate what we are seeing, you are seeing in your data, to the call for revamping the NHS, what do you think attention should be on?
I think the most important aspect is to work with people in that area. Sometimes I do feel people in the academic, they work on research only, but the application of the research is somehow disconnected to real life. It's important to work with people in the policy and people working frontline in the NHS. We might show something like it works on paper, but people in frontline, they may tell you this doesn't work. So right now we are transforming our research, not only work on data, but also to work with people, doctors, nurses, and also patients like experience in this problem. And for example, we recently started a new project to contrast a successful area who has done excellent work in early diagnose, and then an area which they haven't done so good, and then we look for them what area they have done good and what area they could have implemented, learn from the successful story from the other area. So I think that's the key to collaborate, like to work with people from different background. Also, if that possible, like you contrast two area first, but then how do we expand to nationally? That will policy people came in, you need to have nationwide policy to make sure like it's available to every area in England.
Yes. So for you as a scientist, what attracted you to this line of research? So what was your journey like getting to this line of research?
I think I'm quite relatively young to inequality research. So my interest in the past few years was mostly around data. So I'm very interested in numbers and statistics and all sorts of techniques using epidemiology. So what UK has very good research platform because not only NHS is public service, but their data collection is, I wouldn't say the best in the world, but one of the best in the world. And linkage is improving. And since COVID, I'm sure you would also agree, COVID has pushed a lot of data science development in this area. So as I said earlier, one would not imagine there's inequality in public health system like NHS. But when you observe what in the data, and at least for me, I start to think, oh, what can I do? Use my technical skill to tell people this story. But at the same time, right now I'm at the stage to moving away from data, like I mentioned earlier, to work with people in the policy, work with patients, work with clinicians to understand the story behind data. So yeah, it's fascinating.
So how far have you gone with your program at the London School of Hygiene and Tropical Medicine?
So I started in 2021, so it's almost 4 years now. Yeah, I'm an assistant professor in epidemiology. Yeah.
That's awesome.
Thank you.
Impressive research. So thank you for speaking to me. I really enjoyed having this chat. So how do I pronounce your name so that I don't?
Suping, yes.
Suping. What does that mean?
Well, so it means it's quite difficult to explain. Okay.
Come on, give it a try.
Okay, so I'm Chinese. I think my name was given by my dad. I think he wishes me to have a very pure and, adhere to your heart life in your future. Yeah.
That's deep. Thank you so much.